Well, good afternoon, everyone, and welcome to our February KPQC Learning Forum. Happy to have you all. I will hand it over to Tara to get us started.
Hi, everybody. Um, Hannah, I just saw your chat. It's okay to eat. It's okay to eat. We do it too, weirdly enough. Hey guys, Tara Stroda. For those that are, I think we've added quite a few new faces and email chains to the world of KPQC this last few months. And so the face behind the name is going to happen today. So I am one of the maternal QI coordinators with KPQC, along with Carrie Smith, my colleague. We are led by the invaluable Jill Nelson and Tiffany. Gosh, Tiffany, what do we say? Tiffany is all the things that we want to be, including being in charge of us, thank God. So if you have questions or have concerns about how your Zoom is working or you're missing pieces, don't hesitate to chat with Tiffany directionally. But we always start off our learning forums monthly with, as you can tell, we've trained folks well, their name and their agency in the chat. Why do we do that? It's because you're like kindergartners and we're taking attendance, and we really do keep track of how many folks attend and from what area of the world you're joining us. So we use these webinars every month to provide free education and conversation and what we call rapid response, which is how we'll start this noon session off. I want to tell you all, which is going to be the first hot topic, so to speak, is that we're going to start to change some things up on the learning forums this year. We did get some feedback this last few years that the noon time is hard. Um, that once a month is hard, or hey, we want more, but we want some directional coaching. So we're going to start off with something different right away. The first 30 minutes of the Learning Forum will be an overview of our new bundle, and the topic at hand is hypertensive disorders of pregnancy. We are not stingy. If you're enrolled, if you're thinking about enrolling, or if you can't or don't enroll because you're not in a facility that can enroll, we still want you educated. And so Carrie and I are going to split this session today. I'll talk to you about the importance of this bundle again, but also really just start to talk about the actual problem, which is hypertension in pregnancy and the postpartum period. Then after the first 30 minutes have been reached, or we reach that topic end, then we're going to break off and let those of you that are not enrolled or are not going to enroll enjoy the rest of your lunch hour, and the rest that have enrolled or are planning to enroll, please stay. We're going to do some directional coaching on enrollment, next steps, and answer some questions that many of you have had as you get going. You should know that, speaking of enrolling in our bundle, for those of you that can, we certainly are still enrolling. We extended the deadline, but only by a little bit. You've got a few days left. The end of this month, the 28th, will be the last time, period, that we're going to enroll anybody in this bundle. So to date, we have 30, actually, we have more than that. This was updated just a few days ago, but we've gotten some great enrollments just in the last 48 hours. So we were at 32 birthing facilities enrolled, which is awesome. That includes 4 new facilities that were not enrolled at FTI, and we are thrilled to have you all join us. There are 6 4-trimester hospitals, and actually that number's wrong. We're down, I think, to 4 of our previous hospitals that have not enrolled yet, but we're excited to see you guys' enrollments come through. We know life is busy. We know that this is sometimes an administrative level decision or a capacity decision. And we want you to know that if it's possible, we would love to have you stay on. And then we've expanded our Kansas Perinatal Quality Collaborative arm to non-birthing facilities. So hospitals that are not birthing facilities, but that want to enroll in the bundle, and we'll call it a impact part of the bundle, right? So being trained and training on post-birth and other things that we'll talk through in the second half of our session today. So again, that number is climbing even since this was posted. Exciting stuff. Next slide, please. So if you haven't seen this once, twice, or 25 times, that's my fault. This is what we call our fact sheet. For those of you that have been around for a while, the fact sheets change as we continue down bundle. So for our 4th trimester initiative, we use the fact sheet to get information out, but we also told its success stories as we went. And that's no change here. So our severe hypertensive bundle, severe hypertension and pregnancy bundle in Kansas, has its Kansas specific fact sheet. Why is that important? Because those of you that are enrolling or learning about this for the first time need to know the why. I would want to know the why if I was changing policy, procedure, and conversation at my facility. And so we provided that to you. On the left is the why, our call to action, specific Kansas data, and the follow-up to the pediatric need with severe hypertension and pregnancy. It does impact mom and baby. The bottom part is timeline. We had feedback from last time that you all didn't know exactly when and how this was all transpiring. We understood. And so we've tried to line ourselves up to a very tight deadline, which means we're going to rock through this pretty quick. And then on the right-hand side, should look familiar. It's pretty colors, thanks to Tiffany and her team. But bottom line is we are reinventing or updating the way that we recognize and respond to hypertensive disorder with diagnosis, protocols, and screening for those things that are connected. What are her coexisting conditions? What are the mental health pieces, substance abuse disorder, intimate partner violence, and SSDOH needs amongst family planning and others? What are we doing if we have to elevate care? What if she qualifies for higher level facility need? Or if you're the higher level facility, what does that mean when you get her or have her and stabilize her? What if she's doing well discharged outpatient? And what do we do for the outpatient portion of care? What are the criteria and the protocols that are now going to be statewide standards of care? And how does that follow through to the postpartum visit that we know has really amplified our identification of concern and follow-up of concern? So there it is. There is the next 2 years of your life. Many of you are already halfway through this because you do it already as your baseline, but we are going to have you question and add and share out what you've already accomplished. And we're excited about that as well. Next slide. There's always some boring paperwork that I need to make sure you all know about. I apologize. I don't like paperwork either, but here we are. So the enrollment packet was sent out to everyone that we knew of. I think that's a fair assessment. We were assisted again by our marketing guru, who happens to also be the Kansas Hospital Association president, Karen Brayman. She's underpaid in our world. So the story there is we wanted every hospital, birthing and non-birthing facilities across the state, and our birth centers for sure, to get the enrollment packet, take a look at it for this bundle, and to fill it out if they wanted to enroll, send it back to Carrier Eye. If there are questions you have about the enrollment of your facility or the form, stay tuned. We're happy to answer that on the second half of the session today. Next slide. So what are we going to do? This is all lovely, but let's get down to business. And Carrie and I and Jill and our new colleague, Michelle, couldn't agree more. So Q1, we've separated ourselves, or I should say our goals into quarters, and sometimes quarter and a half or 2 quarters. But really we're focused in this first 3 months on launching, which we've done or continue to do across the state. We're also eliciting the collaboration and interest of our colleagues across all, we'll call them agencies and interest groups. So ACOG, ACNM, AAFP, A1, everybody, KBEN, everybody, we want you engaged and involved for sure. And so again, continuing to extend the why and the reach as we launch. Of course, those of you that have enrolled, you know that you got a follow-up email that told you that there's some data we need to collect. Again, that'll be discussed in the second half. And then we're quickly going on. In fact, you're going to notice that today we're doing some of the Q2 information because we know how important the actual diagnosis evaluation is in this bundle. Quite frankly, if we don't talk about accurate diagnosis, terminology, and the identification of hypertension, as rudimentary as it may seem to many of you, this is in fact a problem. This is like closing your eyes and saying, yeah, everybody gives labetalol at the right dose. Well, first of all, I would challenge that conversation that not everybody is using the right terminology in hypertensive disorders of pregnancy across the state, and we see that on chart review. Number 2, response times are struggling. So thankfully, this is not a new wheel, and we didn't have to invent it. And so we connected with the National AIM group. We are using the severe hypertension bundle to set that standard of care and make sure everybody is corresponded. But we're going to start with education and expect you all to share that education, figure out your own way to make sure everybody's caught up, and then we'll roll it out. Next slide. Same thing. That's just repeating myself. But again, once we hit the second quarter, so April, if not a little bit before, we will really start to hone in on making sure everybody's meaning hospitals, birthing and non-birthing facilities have protocols in place, Carrie's going to talk about this, but we'll revisit post-birth education, hugely important across the state, even for those of you that have been trained. And then hitting the conversation of community level or statewide recognition of the problem. Next slide. The pieces of this that you all need to know, again, both enrolled facilities and non-enrolled facilities, is the amount of resources available to you in this bundle with a seemingly easy topic. Meaning, when I say hypertension, I bet at least 99%, if not 100 of you on this webinar know what hypertension means. So what we have to do next is educate about post-birth and when do we yellow flag or red flag a patient with hypertensive disorder or symptoms. What algorithms are in fact best practice models? That's the second thing. ACOG and CMPQC have made this easy for us because they're already precedents and they're well studied. And so we will review your protocols, help you develop protocols and options for best practice models in your facility. And then this is the last bullet, but really what we're talking about today is what do we call it and how do we know it's hypertension? The nomenclature was changed years ago, but again, even in my own practice as a nurse midwife, I've had to make sure that I'm using the right terminology. And oftentimes provider to provider, we're using old conversation and maybe even old techniques to diagnose and to evaluate and treat. And then, of course, the patient. It's all about post-birth. Again, I know you all have heard this term. It's our acronym, the POST versus the BIRTH. Very specific. Again, I'm not going to take the wind out of Carrie's sails, but post-birth education across the state continues to be the most important thing we're doing. Why do we know that? We know that because the recognition is increasing of a yellow or red flag condition that brings the patient to care. And we know then that we need to be ready to activate when they come to us or call or triage or my chart or whatever version of connection the patient has if she has one of those post-birth identifiers. And then there's always data because, you know, the QI people need it. And so we'll walk through some of those data collection pieces. Don't be intimidated by it. It's never been our number one focus, but we absolutely want to see the change happen. And so we'll walk through that as well as we go through this bundle. Next slide. So, you know, it's February, and yes, it's after Valentine's Day, but Jill Nelson has a background. I love that her screen is off because she's going to shudder a little bit. Jill Nelson's background is in the arts, and every time that we start to think about how we're going to call something or how we're going to envelop change and how we're going to impact patients, really hits the emotional cue of boom, and sure enough, help save the hearts. Yeah, Jill, that's what we're doing. You're right. It is as simple as helping other people. And this new model that we're introducing across the state of hypertension prevention and care, those are two separate things, but absolutely feed into each other, is about heart disease and heart conditions and related conditions of hypertension. And in fact, we want to help save the hearts. Next slide. Many of you have seen this before. I'm just reminding you of the why. The prevalence of preeclampsia. Those of us that are at the bedside already saw this. We already knew this. To see the data in front of you is like, holy cow, that is what's happening. So from 2016 to 2023, this is Kansas data. So don't be thinking this is some other state or country level. This is our state. Significant, vast increase in the prevalence of preeclampsia. So annual percentage change of 5.28%, that is not okay. And that's why we chose this bundle. Next slide. So again, how do we make this work at the local level, and how does the state adopt a standard, right? How do we all fit into assuming a new standard of care? And we like to visualize it as a model. And so SHTN, I'm chuckling a little because our teenage children will make their own version of what that means, but it in fact stands for severe hypertension model of Kansas. No, Jill, don't apologize. Be safe, please. We just love having you. So severe hypertension model for Kansas. This is how this will look at every facility who's enrolled. If you're a non-birthing facility, of course, it's an abbreviated version of this, specific for your evaluation and treatment of hypertension in your ED, urgent cares, et cetera. But this model will be shared across the state. If you want a copy of this quickly, you'll see it when we send out this slide deck after our meeting today. But if you want to talk about it or have questions, reach out. But this is our goal, guys. This is what we're teaching, educating, renovating about the Kansas model for how we respond to severe hypertension in the pregnant and postpartum period. It includes the 4-trimester initiative, as many of you can recognize. That's because we're not stopping that initiative. We're just focusing in on the severe hypertensive moment in that period. Next slide. So we're going to go back to the basics. I might take some of you back to nursing school. I might take some of you back to med school. I might take some of you back to 5th grade. I talked to some of those folks locally today and taught them about how to listen to their heart rate. And you forget the moment where you got the aha, I hear it. I recognize the graduated level of learning. And so today we're going to talk about the diagnoses, including pregnancy and postpartum. And for the 900th time, postpartum is not just the first 6 weeks. Okay. Postpartum is up to 1 year postpartum. Next slide. All right. So again, you do not have to read all of this. I put this on here so it's a reference guide. Again, you'll get this slide deck after our meeting today. I would tell everyone who's listening into this call to watch that first link that you see there and send it out to all of your staff, your colleagues, anyone who takes care of pregnant and postpartum patients. Administration, it's a quick video, you guys. It's not a long one. And so the piece of the why and what this bundle is about in a quick, we'll call it a little longer than an elevator speech, is there. So love it. Share it out. Explain it to your staff. Next piece is, again, what are the things that your hospital can look at quickly and make sure that your hospital, your facility is doing the current best practice model for severe hypertension and pregnancy in terms of identification, et cetera. At the top right, you see a screenshot of an example of that hypertensive toolkit from the California initiative. I don't know if you see there's lots of words on this page, but that document itself is 238 pages. And I happen to have my copy right here. I love this. This is my new nerd out moment because I think this, along with the AIM bundle resources, is like, yes, this is what we all should be doing. Guys, you don't need to read 238 pages. What you need to focus in is the toolkit and the patient education checklist and the pieces that would correspond to what your hospital, and take a look at it. See if it matches or nearly matches what your facility is doing. And that is part of our goal for the next quarter. How to properly take a blood pressure. Let's take it more further back. Like, I'm not going to tell you something new. You know this, but not everyone who takes a blood pressure knows how to take a blood pressure. Patients don't know how to take their own blood pressures. Many staff, I would tell you, physicians and midwives haven't taken a blood pressure in a long time and may not remember cuff length. How do I play? Like, it sounds ridiculous, but I will tell you that the accuracy has been studied, and there's a problem there. So I found what I believe to be the best, it's a very rudimentary flyer about how to properly take a blood pressure that could be staff and or patient driven education, but it's a very simplistic way to describe. You will learn that in the next few months, we're going to launch a collaborative work group. We've already been working on it and excited to take this to the outpatient and inpatient setting so that we teach patients how to accurately evaluate their blood pressure, make sure staff knows. You guys on the administration level will get links and resources to how to teach your staff how to take a blood pressure. But please don't miss this part. And I'm saying that to you today because even as recently as 2 weeks ago, in this very area, I had to remind patients because it was -20. I had to remind nursing staff because it was -20 to take a patient's sweater and coat off to take a blood pressure. So if we're still struggling to decide how to take a blood pressure and the accuracy is in question, we got a lot of work to do, folks. So share this out, make sure that you're talking about it. How do you take a blood pressure and documentation of it? And then again, the CMQCC, that group has created a wonderful YouTube video for home blood pressure kit monitoring. Again, we'll share this out further. I just want you to know the resources that are available and how exciting it is to not have to reinvent the wheel of this. Next slide. So in front of you are the diagnoses encompassed in hypertensive disorder of pregnancy. Note that we talk about severe hypertension of pregnancy. Okay, don't get lost in the fact that that's a separate diagnosis. It's not. The point is, these diagnoses, folks, are what should be used and used only. Now, can someone come to you with a hypertensive event? Sure. But these, what is it, 5 diagnoses, 5.1 or 5.5, whatever version, but these are the ones that you should be using your facility, providers, staff, and when patients understand what they are been diagnosed with, they should be able to evaluate, read, and understand what their diagnosis means in this list. Next slide. Um, awesome. Hey, Tiffany, hit one more slide forward. I think I'll go back, but yep, go back. Next one. Forward. Yep, thank you, hon. So again, the story of what is diagnosed as chronic hypertension versus gestational hypertension, right? So I'm not going to read this to you. You are adults. When you get this slide deck, I would really encourage you to print this out. It's on ACOG's website for free. Print it out, send it out, put it up, and make a word find, make something fun in your staff lounge. Do something to incentivize folks. If you recognize they're using the wrong nomenclature, you need to say something. What happens in that moment is if a blood pressure or a diagnosis is found to be this, and we do not follow and chase that correct identification or diagnoses, the algorithm is immediately wrong. And what we find is that we don't want to admit that there's preeclampsia happening. We don't adequately identify it and treat it, and we're believing it's just because she's anxious or because she's in a hurry or she has a sweater on. And in fact, there are more layers literally to that story. So again, review this, share it out, look all the way through those pieces, but this is going to be critical as we continue the bundle. And the expectation is that everybody is using the same names and diagnoses across the state now. Next slide. This is that PDF that we talked about. Again, really rudimentary, but I wanted you to actually see it. Next slide. And then my colleagues joke with me that I speak and think in algorithms. That's been my entire life. I'm going to guess on this call, I'm not alone. But what happens now that we've correctly checked a blood pressure, diagnosed a blood pressure, what happens next? Next slide. We don't make a mistake. And again, I put these in a funky color because I think you all need to recognize that when we evaluate charts for the Maternal Mortality Review Committee, when we look at state level data and we hear anecdotal evidence, we're finding consistent mistakes that are changing the outcome. So the first 2 factors and the fact that we will continue our work on birth equity and preventing racism in the state is because severe hypertension or hypertensive disorders in pregnancy is one of the #1 things and times that we see racism and race brought up incorrectly, right? Assuming that someone's skin color has anything to do with their blood pressure and that changes her algorithm is disgusting, and we've seen it happen. So racism might be a risk factor, but race is not in hypertension disorders in pregnancy. And please stop assuming that obesity changes her risk factor or her response, our response to that. Her socioeconomic status, patient's diet, the SALT conversation that those of us that have been around for a while continue to hear, that has some significant impact. Mental health, pain, the let's just get her an epidural and this will fix everything story. Anxiety as the cause, sure, these may be coexisting or contributory, but do not assume that that's the cause of her elevated or severe range blood pressures. Again, this is another resource you can find in that CMQCC document, which is the preeclampsia early recognition tool. It really is good. If you see this blood pressure, you do this. If it's repeated and it's normal, you do this. If it's not, you do that. Like, it is absolutely a great tool for your staff to have at their protocol level, but also a quick sheet. And then post-birth, again, I put Carrie in charge of post-birth because she's so dang good at talking about it. And she'll talk about it here again to the folks that have enrolled. But post-birth is our explanation to ourselves of what requires green light, you're okay. Yellow light, we need to hear from you. Red light, get to us now. And when they get to us, what do we do? And then, Carrie and I, as we were talking about the importance of correct triage, diagnosis, and treatment within 1 hour, we talked about the neurosymptoms piece. And this is brought up in the literature time and time again that immediate triage to a facility must occur if neurosymptoms exist. Okay. Or if she's currently in your facility, she's being evaluated or being treated, and there's a change of neurosymptoms, response must immediately happen. And again, we see that as a major mistake that occurs when we review charts and language. Next slide. Prevention conversation. We know that it's kind of like the fourth trimester initiative. Patients don't start their care typically in the fourth trimester. Rarely does a patient arrive via ambulance postpartum. It does happen. So we talk about that, just like we talk about that may be the first interaction with healthcare or midwifery care or urgent care or any of those things. But we really know that prevention of hypertensive disorders begins in the preconception before there's even a pregnancy occurring, and definitely in the pregnancy settings. And so we're going to connect dots and backtrack, so to speak, to make sure all of those pieces of her pregnancy and preconception care are also part of the initiative. Next slide. Risk factors. This is part of the statewide work I just talked about, and I think that this is 2 slides. Again, Stephanie Wolf and the folks on the KDHE outpatient maternal child health, like the folks that are working really hard on the outside of hospital work, have developed this phenomenal algorithm of how we're going to do this on the outside of the facility. What if we see this? What if we recognize risk factors? How are we going to handle that to make sure that the patient has elevated care? And the orange arrow there points to an important piece, which we even chewed on a little in our own work group. What are the risk factors for preeclampsia? And what are high risk versus moderate risk? And what do those matter? So take a look at that. Again, this is a draft. Please do not share it. Do not print it. Do not do any of the things. Just look and pay attention to that as part of our bundle, that we need to identify risk factors before to prevent, right, preeclampsia versus just responding once preeclampsia occurs. We will decrease the rates in Kansas faster than anything if we can identify and treat and prevent. That is our goal. Next slide. Yeah, that's just a follow through on what happens next in our work tank. And again, great work on the outside with Stephanie Wolf and her team. We'll be back with more of that information, I promise, in the coming months. Next slide. Yeah, so the story about aspirin, I needed you all to see this because I also want to be honest with everyone, and I think we all can be honest with ourselves and each other. The conversation of hypertensive disorders and treatment has changed enough or altered or navigate, there are changes that we have to pay attention to in protocols all the time. One of the conversations that I've heard at the provider level is, what's this whole thing with aspirin? And doesn't it cause increased postpartum hemorrhage risk? And why are we giving everybody aspirin? Or the other part of that is, how much aspirin am I supposed to give? And when does it start? What week of gestation? And how long do we continue it? Well, guys, I pulled this off of off of a resource. There are lots of ideas with that. And so if you're not sure, or your group does something different than the next group an hour away, you're not alone. And if this many expert groups, to include ACOG and many across the globe, have a huge range in how much aspirin is used daily, it's okay. Like, again, we will talk about this. You all that are not OB providers will have to explain to patients why this is important, but providers really need to hold themselves accountable to a consistent decision here. And we're obviously, as you can tell from the second column there tells you the vast difference across the globe and how much we're recommending. And again, we will come back and talk about that at a later date. I just wanted you to know we're still figuring it out too. Next slide. So what do we do with treatment, right? So we've avoided mistakes. We've hoped to prevent. We've accurately diagnosed or excuse me, accurately taken a blood pressure. Now what do we do? Next slide. 60 minutes. If you were like me growing up, I can even hear the ticking of the TV show as I see that picture. 60 minutes, guys. This has to happen. Recognition, response, treatment within 60 minutes. The algorithm you see there is, again, the suspected preeclampsia algorithm. What does this look like? And the delivery plan. But we will go deeper to the specific protocol of recognition to treatment in 60 minutes. This is a hard stop, meaning um, 90 minutes is not acceptable because we know outcomes change quickly. If you can do it in under 60 minutes, awesome. If you're a facility that does not have, it's a non-birthing facility and you need to do it in elevated care, how does that fit into this story? We will help you through that. Next slide. And then the next few slides, guys, we're just going to zip through so we can get to the second half of our learning forum today. But I wanted you all to physically see again what are the now standard the standard protocols for hypertensive disorders of pregnancy and postpartum in terms of therapies, medications, identification, follow-up, et cetera. So this is what should be happening. If your providers are choosing to do things outside of these standards, that is the point of our bundle. And so again, and Tiffany, you can just kind of click through the next few slides just so you all have seen it. Again, these are on the ACOG site with links that we will provide to you. Again, how does this work if I give oral nifedipine? What do we do if we use hydralazine? What do you have at your facility? And when should you use this versus the other? Labetalol, again, many of you already have these and have these in use very well. Let me pause you right there, Tiffany. Go back one slide. I got a couple of questions in the last few months. That's not a huge cohort, but it's enough that I need to stop and tell you all. There has been conversation and questions directed to us about a labetalol shortage in our state. I'm not hearing that that's happening right now. If that is something that your hospital is facing, please let us know just so we can have a pulse on what's going on. But I would tell you, we are not hearing that and not seeing that to be the case. Again, we know that medications come sometimes in supply and demand principle is an issue. Not questioning that, but I'm saying in terms of a global shortage, we're just not seeing that happen in Kansas. Next slide. And then the old checklist that we like to. So, right, print these out, put them at the bedside. What happens when we have a hypertensive emergency, and what are the next steps? Literally, step by step by step. This is a protocol to embed all by itself. Next slide. And the eclampsia moment, right? The moment nobody wants to see happen to a patient. And yet we need to practice this. We need to understand this and understand where the meds and the response team are. Next slide. And then I was in a mood for old TV shows, clearly, when I was making this slide deck. The ED, our friends in the ED, postpartum and antepartum, so pregnancy and postpartum preeclampsia. The emergency department, we know, is actually a very predominant access for patients that are having a hypertensive crisis. So preeclampsia or eclampsia, for sure, we see those numbers happen in the ED more than they just show up at birthplace or labor and delivery or triage sometimes. So the ED is absolutely part of our bundle, which is why many non-birthing facilities are enrolling. Thanks, you guys. And these checklists are specific for the emergency department and phenomenal resources and an embedded protocol waiting to happen. Next slide.
Kara, can I add something to that?
Yes,
Sorry.
please.
I just want to tag on to that to say, especially for our non-birthing facilities, the blood pressure ranges, and correct me if I'm wrong, the blood pressure ranges that you see on the slide before this actually would not fall in a high ESI scoring in the emergency department. So I want to emphasize the importance of taking this information, collaborating with your EDs at your facilities, and making sure that they're adjusting their ESI, their emergency severity index scoring, to account for these, and asking every patient, just like we implemented in FTI, are you pregnant or have you been pregnant within the last year? Otherwise, they're just going to blow past these blood pressures because they see significantly worse all the time from that. So I just wanted to emphasize that.
Yeah, no, and Carrie, absolutely true. And we see that in the chart reviews, don't we? A lot, actually. Postpartum surveillance. So again, don't forget, and I like this picture because that mom is pretty dang proud of that baby, isn't she? And she should be. And yet we still have to be vigilant. And so what does that look like? On the inpatient side, if we're watching immediate postpartum where she's readmitted for preeclampsia or eclampsia concerns, what does the outpatient side look like? And remember the importance of the postpartum visit within 3 to 5 days, sooner or later, in addition to that. So again, your postpartum visits are critical in this moment. And then what do we do for long-term treatment, medication treatment in those who are still hypertensive after delivery? Next slide. Same story. Again, ACOG walks through every step, guys. There, it is all lined out for us. And what does this look on the outpatient post-discharge evaluation? What happens if she's elevated with a blood pressure above certain criteria at home, or on she calls the triage, or she comes in through triage? What are we doing next? So again, we've been through this. She's discharged. It's after discharge, and now what? Again, there are no pieces of this that have not been studied and best practice models created for you all, which is very helpful. Now we need to do it. Next slide. Carrie, I'm actually going to let you take over here. Stay with us for just a few seconds for those of you that are not enrolled or currently enrolled. I want Carrie to talk about next learning forum, and then we'll transition to just the enrollees.
Awesome. Thanks, Tara. For those of you who'll be jumping off the call, we just wanted to highlight that next month, I believe it's March 25th, our entire learning forum will be an in-depth dive into understanding hypertensive disorders of pregnancy. And we have a great guest speaker, Bree Fallon, Director of Perinatal Risk for all of St. Luke's, is going to come. She's also a huge A1 champion, our former chair, Kansas State chair. And it's going to be a great conversation. I want to emphasize we will be talking about the pathophysiology. We'll be talking about why the treatments that we're using, just because I think rather than viewing this as a tasky checklist and treating our patients, you have to understand the whys behind it in order to apply it appropriately in all of our patient scenarios. So make sure you jump on and join us for that next month. And then also know that you're going to get you'll be receiving a recording of this session along with your PowerPoint. So all those links that Tara included, you guys will have access to, and be sure to review them with any of your colleagues and staff. And Tiffany will be sending it out, so you'll get it from the KPQC email. So be on the lookout for that. Next slide. One more for me, please, Tiffany. Thanks. Okay, so this is where we let you off the hook if you're not enrolled, but before you go, I see a lot of names who did not put their name and facility in the chat box, so please throw it in before you log off. And that way we can make sure we have accounted for everyone who joined us today. And also, if you're staying on, make sure your name and facility has been in the chat box as well. And if you're not enrolled yet, but you will be enrolling before Friday, by all means, plan to stay on for this too. Perfect. Okay. For all of our facilities, save the date. April 23rd is going to be an in-person conference that we're hosting. It's going to be in Topeka at the Sunflower Foundation, and it's going to be from 9 to 1. We will serve lunch, and we also utilize that opportunity for you all to get to meet with the KPQC Executive Committee. It's great for them to have the opportunity to meet the people who are out there on the front lines doing the work and taking care of the patients, as it really makes a difference in helping when they're formulating the plan or what we're going to be doing next. It's just great to form those bonds and relationships. So I need all of you to put that date on your calendar. It will not be hybrid. Again, it is all in person. So plan to attend from 9 to 1 on April 23rd. I believe so, Kayla. Yes, did I put the wrong? Will you go back one for me, Tiffany, please? I believe so. Yes, Kayla. Okay, next slide, please. What we want to offer the opportunity for during this last part of the learning forum is just to open it up for any questions. For those of you who have enrolled, who maybe have not completed all of the REDCap data or completed the breastfeeding survey, just to open it up for questions. I happen to be a big data nerd, but I know that that does not always set well with everyone, and that's okay because there's a lot of things that I don't enjoy. So I really wanted to make sure that you guys had the opportunity to ask questions. We also wanted to make sure that for all of our new sites, new facilities, our birthing facilities specifically, we want to let you know that we are going to be setting you up with our outside partners. So our community partners, Kansas Connecting Communities, Mavis for our inpatient, our intimate partner violence, High Five or Kansas Breastfeeding Coalition. If you are not a High Five designated or baby friendly hospital and you're just looking for some guidance, especially since we will have that neonatal component of this bundle as well, we just want you guys to know that we have resources already set in place that we want to make sure that we're connecting you with. So stay tuned and be on the lookout for that. And then for our non-birthing facilities, just know that there is a fact sheet coming that will be specific to our non-birthing facilities. So stay tuned on that. And then next slide, please. Resources. Before I get started on this, I really do just want to pause. And if you don't want to speak out loud and you just want to put your questions in the chat, feel free to do that too. But let's start with, do any of you have any questions related to the data that you needed to enter for REDCap? Or I've only gotten 11 of about 35, 36 breastfeeding surveys back. So I'm going to go ahead and pop that link in the chat as well to give you guys the opportunity to have access to that and make sure that you're completing that and getting that back to me. So give me 1 second to grab that. While I'm doing that, any questions?
Hey, Tiffany, can you go forward one slide for us, please? If you have not, while Carrie's grabbing that, if you have not opened so you've enrolled, send us your packet, then you got an email from me that had a couple links, Carrie's breastfeeding survey link, and then the link to what we call REDCap, which is how we're collecting data. For those of you that were here for 4th trimester, that was the QHI website. We're going with a different option now, and have some great colleagues that are now helping us to keep track of data. But what you'll see pop up on REDCap is that left-hand side facility and reporting period there. But again, it's just a matter of staying active and understanding what the heck we're asking for too.
Perfect, thank you. Okay, I've popped the link in the chat for anyone who has not completed the breast pumping survey. Please feel free to click on that and get that done. Just again, I only have 11 responses back so far, and I know I have many more facilities out there enrolled that haven't completed that yet. Go ahead and click to the next slide, please. I also think it's important that we kind of highlight and go over as we look at how hypertension is involved with our SMM indicators. For those of you not familiar with your perinatal core measures, the PC01 through 06, there's also a PCE 07 that's really focusing on your SMM indicators. And this is just a list that we wanted you guys to be aware of any diagnoses that are incorporated into that. So just as an awareness piece, we wanted to make sure that this component was out there. And then I know we also talk a lot about maternal mortality, but I think this is a great time to remember that related to hypertension, it really is the maternal morbidity that we're looking for. The pregnancy complicated by preeclampsia or the undiagnosed chronic hypertension can lead to significant morbidity later on in life. And so that's why we really want to drive home the importance of this bundle in early recognition, detection, treatment, and then making sure they have adequate follow-up as well. Next slide, please. For that breastfeeding survey that I just put in the chat, you will see that the reason why you were completing it is because we have that neonatal initiative incorporated into our bundle. And really it's to assess how many facilities, which should be by the end of this, every single one has a mom or patient pumping within 3 to 6 hours if her neonate is transferred to a different facility or to the NICU within her facility. So the importance of really getting that pumping initiated. And as a gentle reminder, in both of those situations, there's not a lot she has control over in those. So this is a great opportunity to at least hand back a little bit of something to her to say, this is what you can do in the meantime. So that's why I'm having everyone complete that breastfeeding survey.
Hey,
And
Carrie.
why
Michelle Caldwell is not able to access that via the link.
thank you. Okay, Michelle, hold on one second. I'm going to try one more thing and then you retry it for me. Try this and let me know if that's working. Okay, perfect. Thanks, Tiffany, for letting me know that. If anyone else has any issues too, just shoot me a message and let me know and I'll see what I need to do. It will never be a forum or any meeting that you're on where some tech is not an issue. So we're just going to roll with it this time. So anyway, just back to that, just as a reminder, the goal is to get every facility to implement that practice. And then to acknowledge too, that if we have a mom who's being transferred out of that facility, obviously stabilizing her and getting her to the right facility is the most important component of that. And then once she is there, making sure that that is a piece that we want to highlight on that as well. So next slide, please. Post-birth warning signs. For anyone who's been enrolled in FTI, you will know this is something that we really drove home and was a big part of our last bundle, as it should be. As Tara mentioned earlier, it's a huge game changer, just in that it gives visual recognition to patients in a very easy and concise manner for the things that they should be keeping an eye on, and not just patients, but their significant others. And we've heard story after story of family members or even community members, someone in a church who was like, I noticed this about this patient and recommended that she go in to be seen. So we did implement post-birth training in all of our FTI. I also know that facilities probably have new staff by then. And then we have new facilities who haven't done the post-birth training. So you'll see training dates listed there below. Links to register will be coming, so stay tuned. But we're going to continue on with that training. In 2023, A1 updated it, and it really, they really, I think, did a phenomenal job. It's a little over an hour now, but did a phenomenal job of incorporating birth equity in there, and really highlighting the importance of access to care for all. So I think it was a great resource and great tool that we want to make sure continues on into this bundle as well. So note the training dates, and then know that the links for these registrations will be coming, and I am going to ask for people to actually register to come for this time, just so that I'm not blocking out time and calendars and not have anyone join. So stay tuned for that. Next slide, please. Any questions, you guys? And did anyone else have any issues logging into that survey? Okay. And I know
I'm
that we
still
keep trying.
not.
Go ahead, Michelle.
So sorry. I'm
No,
still
you're
not
good.
able to, but I've had trouble before. I don't know if my hospital is blocking some of that. I usually have to do things you guys send from my phone. So I don't know if you're able to email that out. I can access it on my phone.
Yes, if you want to send me, you want me to just send it to the email address I have for you?
Yes, please.
Perfect. Okay. Yep. I'll do that from this call. I will send it out again via email for the same reason. You're absolutely right. There are some facilities, because it is a Google form, that will block and not allow you to go in and complete that. So absolutely, I will get that done for you. And I just want to reiterate, I know people think hypertension is old news and we're already doing it in our facilities, but I just want to remind us that CMQCC put these bundles or these resources out a decade ago, you guys, 2015. And yet we consistently hear that providers, I'm just going to say it, are going rogue and not ordering what is standard of care or best practice, or that our nurses are not acknowledging or making excuses for why we have blood pressures, or we're not treating appropriately within the 60 minutes, or we're giving MAG without an antihypertensive. That the list is really, really lengthy on the issues that we're seeing when it comes to treating hypertension and knowing tension, God, I can't talk, and knowing the morbidity that is related to that. I just want to emphasize the importance of, even though we've heard this before, you're going to hear a lot of repetition during this bundle because it takes a lot to drive it home. But make sure that that you're looking at your practice in your hospital and comparing it to the algorithms and the resources that we're sending out. We're going to ask everyone to take a deep dive into your hospital policies or protocols, and making sure that they align with what the guidelines are stating. We're going to make sure that we ask people to look at your time to treat. And that's going to be both on your units and you talking to your emergency departments. If your postpartum patients are coming through the ED, it's just as important for them to be treated in that 60-minute time frame as it is for the pregnant patient to be treated. So a lot to consider here, even though I feel like people hear hypertension and like, oh, we've been doing that for a long time. We have a long way to go, and there's always opportunity to do better. So Tara, did you have anything that you wanted to add?
Nope. I think that for those that have, and my computer is not behaving, so I apologize. But if you have questions about enrollment, or you have questions about data collection, or you have questions about what's next, Carrie and I are available. Do not hesitate to reach out. But excited to get going to the next steps, and excited to see the changes happen pretty quick.
Perfect. Well, if there's no questions in the chat, nobody wants to unmute and be the brave ones to ask the first questions, then we'll give you guys a few minutes back in the hour. And we look forward to seeing everyone in March on the Learning Forum, and even more importantly, seeing everyone in person in April. It's so much fun to get together in person and see each other's faces and share what we're all doing at everyone's facilities and not reinventing the wheel. And really just sitting around the people who share in your passion and who are out there working to accomplish the same goals as you are. So have a wonderful rest of your day, and we'll see you guys next month.